You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. Today's episode explores telehealth, the explosion of virtual visits during the COVID-19 crisis, the expectation that usage will remain high following the COVID-19 peak, and its impact on health IT and patient outcomes. Our panelists are Senior Health Information Technology Consultants Gary Austin, Ken Kleinberg, and Jocelyn Keegan. Our guest today is Brian Bamberger. He is the Point of Care Partners Life Sciences lead and recently led a landscape analysis of telehealth with a focus on creating pharmaceutical company action plans. I hope you enjoyed today's podcast and that you'll share your topic ideas with us by emailing us at podcast@pocp.com.
Good day, everybody, and welcome to the ongoing adventures of The Dish on Health IT. I'm your host, Gary Austin, affectionately known as Lumpy. We at Point of Care Partners are health IT consultants with 100-plus associates in over 35 states. We work across all stakeholder groups, payers, healthcare delivery, pharma, health IT vendors, and government agencies, and we're viewed as an independent, trusted party, the Switzerland of consultancy. With me on The Dish on Health IT are my two co-hosts, the lovely and talented Jocelyn Keegan from Boston and the talented Ken Kleinberg from upstate New York. How about a quick hello and opening comments from Jocelyn and then Ken? Josh?
Thanks, Gary. Excited to join. My name's Jocelyn Keegan. I work for Point of Care Partners as our practice lead. I actually spend the majority of my time focused on payer-provider collaboration and topics like prior authorization and overall, really, how do we improve workflows and data exchange between the different stakeholders within health IT. I've spent about 25 years in IT in general. I spent the first half of my career in financial services, building product, and have been excited to be solving these challenges in health IT for the last 10 years. Really excited to talk today about telehealth and really how do we start to take advantage of a lot of the capacity that's been built into telehealth over the last decade and really being able to make it come to fruition and keep it going as we come out of the COVID-19 crisis.
Great, thanks. And Ken?
Yeah, hello everyone. Ken Kleinberg here. I serve as practice lead for innovative technologies for Point of Care Partners. About 40 years working in IT, worked as an industry analyst at Gartner, the advisory board, Chilmark, and a couple of health IT vendors. I've always tried to stay at the leading edge of technology. I live here in upstate New York where we're waiting for what could be 3 or 6 inches of snow here in the middle of April.
Wow, great. Good way to run through April. That's enjoyable. So, today on our panel, in addition to our Dish on Health IT gang, today we have our very first podcast guest. So we're keeping it in the house with Brian Bamberger, the Point of Care Practice Lead for Pharma and Life Sciences. Brian has in excess of 25 years in health IT, last 10 at Point of Care Partners running our practice, and is a national subject matter expert on pharma. Brian, could you introduce yourself so our listeners can hear your melodious voice and provide a bit of your background?
Thanks, Gary. Appreciate the opportunity to be part of the team today. My first podcast, and looking forward to participating in the discussion. I've spent about the last 25 years, a chunk of time at IMS Health, now at Cubia, other adventures, media, largely around the pharmaceutical industry. And have been involved with electronic prescribing to start with, and then EHRs probably over the last 16 or 17 years. And the last 9 years at Point of Care Partners, where I lead the life sciences practice for the organization. So lots of work with pharmaceutical companies and involved in other projects with payers and intermediaries and so forth. So glad to be here.
Great, excellent. Thank you for joining us today. We appreciate it. So now let's get on with our discussion panel. As we identified in our last podcast focusing on COVID-19, one of the biggest challenges that we're seeing out there is a massive increase in the use of telehealth to deliver both routine and pandemic-driven services. So Brian, why don't we, let's set the stage here. How do you go about defining telehealth?
Well, Gary, a lot of people use a lot of different definitions and maybe even have some misnomers about what goes into telehealth or starts thinking it's only certain components of it. We're going to split telehealth into four distinct groupings. The first is virtual visits or televisits, or sometimes called telemedicine. And there's really two types of activity there. One is when someone sees their regular physician. So they have a cardiologist, they have a cardiology appointment, and it happens over a virtual visit methodology. And the second, and I think an important distinction, is one that is with an on-demand kind of situation. Maybe the payer sponsors a service where you can get on-demand instead of going to an urgent care center or an emergency room. You can contact a physician, have a visit, maybe a dermatology visit. You don't have a dermatologist, you're able to get one on demand, those kinds of situations. So that makes up the sort of virtual visit or televisit portion of the market. There's also a behind the scenes kind of what's a little technical name, asynchronous communications. Essentially, that's messaging, usually between physicians. So maybe your primary care physician in a rural area then goes to get a consult with a neurologist to see if further work is needed. And so those kinds of neurology consults would be part of asynchronous communications. Provider to provider, and they're going to send information over, maybe some scans, some readings, some background documentation, and they're going to message back and forth, maybe even with video, or maybe just audio, and send information back and forth. So that's asynchronous communication. The third category is remote patient monitoring. So this would be a blood pressure cuff, continuous glucose monitor, scale, for say a heart patient with heart failure. Might be important to monitor their weight. So all of those devices might report back to either the physician or a recording center that would provide information back to the physician's office about what's going on. And then the last one is mobile apps. So everyone's familiar with mobile apps, right? So they're going to be apps that you get on your phone, that you download onto your phone and use. Physicians have apps that are specifically designed for them. So those categories all make up this whole telehealth definition. A lot of the focus today and has been over the last few weeks have been on telehealth themselves, virtual visits themselves, and the uptick that we've seen in the marketplace because folks can't get to the doctor or don't want to go to the doctor that need routine care.
So tell me a little bit about these rule changes that CMS has put down around telehealth. It seems like all of a sudden telehealth has just exploded. Part of that's, I guess, because of the COVID pandemic out there, but there were some structural rule changes that seem to just allow this to explode. What can you tell me about that?
Sure. In working with the process and the emergency that's going on now, the Federal Health Emergency Declaration gave CMS and others some latitude. And so the rule changes I really categorize into three main buckets. The first is that telehealth and especially virtual visits were formerly relegated to the rural health patient not being able to get to a specialist office. And so there were situations where there were a patient might have to travel 2 hours to get to a major metropolitan area to see a specialist, and that was reserved for these virtual visits. The second is that the technology that had to be used had to be a dedicated, specialized technology, secure, but dedicated to virtual visits. And the relaxation of the rules there, at first, the relaxation was to be able to use things like Skype or Zoom or other kinds of modes of communication that were secure, not TikTok, right? This is secure communication between the doctor's office. And those pieces were, it was the initial relaxation. And then one more came, which said that it didn't even need to have video in it any longer, that it could just be a phone visit, because there's some folks that just can't get, the equipment to work the right way. They don't have the bandwidth and so forth. And then the last component was a reimbursement component. And there, instead of paying a virtual visit at a lower reimbursement rate, they moved that to 100%. So that removed any problem that a practice might have in saying, well, we're losing revenue by not having these patients come in. So we were on the phone, our point of care partners team earlier today with someone who was working in a practice, said they weren't able to do every visit virtually, but they had increased steadily over the last few weeks, more and more visits, both proactively reaching out to patients and having patients call in and saying they needed support. And, while there are challenges in bandwidth and so forth, the uptick has been great. They think, and that person's opinion was, it was going to continue because it's a great way, again, to save on the travel. Some patients, like a patient with congestive heart failure, really can't, necessarily make that walk from the parking garage to the elevator, up the elevator, down the hall. All of those components, it adds stress and taxes their life. So, they saw it continuing on as time went on.
Or if you live in some place where, let's say, 3 to 6 inches of snow is falling today, maybe there's an opportunity to use telehealth there too, especially if you're disabled or mobility challenged or whatnot. So how has telehealth changed the industry in, say, the last 60 days here, basically since the COVID came full bore? Jocelyn, how about from your perspective as both a health IT leader and also as a public official?
I think it's interesting. So I didn't share in my intro this go round. In addition to working in health IT, I'm actually an elected Board of Selectmen member in my town. And so I've had this really interesting view into the readiness of all of our local municipalities in readying for the challenges really across all aspects of small town government on how to handle, sort of this onslaught of care that's coming towards us. There's a couple thoughts. I think that on the professional side, I get to see organizations. I have this really interesting, unique seat from a Da Vinci perspective that I get to see inside of a lot of, I would say, our more innovative providers, payers, and vendors in the market. And in just in informal conversations over the last month, have really been able to understand sort of people stepping forward. So a couple trends I've seen. As we all understand, the ambulatory practices are really getting hammered financially by what's happening out in the market, right? Visits have, halted, and as Brian has described, those practices that are more innovative, that have a strong presence already or had tools that were already rolled out, have been able to ramp up those capabilities. And I think that the observation is a great one. I'll speak a little bit sort of on my personal life. I was able to convert my kids' annual checkups, right, to a virtual visit. And my doctor used a Zoom invite, right? Literally sent me an invite 5 minutes before the appointment, very low tech. But I happen to be a member of a practice that already has capabilities of 24/7 coverage of call-in lines. They're a former ACO, and so they do those things because they're the right things to do to keep costs out of the system. Now what we've given is really a mechanism both from the feds and then from the large insurance plans to actually get compensated for that work. So I agree with Brian. We're moving to a world where people are recognizing that meeting virtually, whether it's a telephone call, if that's all that's needed, or a video call, that's sufficient, and that people should be compensated for that work because it keeps people out of practices that don't necessarily need to make the trip into the practice. So I'm encouraged that people have sort of flung themselves forward and are figuring out that technology, sort of, patient by patient, and making it work. I'm also seeing organizations, professional organizations. So I get to work with the folks at AHEMA because they're really actively interested in supporting the work that we're doing with Da Vinci. So I get a lot of their mailings, and the community aspect of the sharing of information as people understand how payers are coding for specific coverage. Just that information that's flowing, sort of best practice cheat sheets between each other in the organizations, these large scale associations being able to help sort of disseminate that information as quickly as possible so that provider organizations that maybe don't have access to CMS or don't have regulatory folks to be able to capture this information, they're really doing a great job through their professional organizations of just getting the information in people's hands of what they can do, what they can't do, how to code it so it'll get paid, which is incredibly important, right, for our multi-specialty practices, right, primary care practices. And then I would say lastly, with my board role, it's been amazing to watch really on a volunteer basis and using our professionals in town, like our firefighters who are our primary emergency response folks, work together to create an informal volunteer network of nurses and care providers in our community that are literally manning phone banks and signing up people in town that don't have access to virtual care, literally giving advice and best practices via daily podcasts to our community to tell people, if you don't know what your telehealth tool is right now, go figure it out now before you get sick, and giving that advice to people. And that, people like my parents and my next door neighbor are using words like telehealth to be able to understand that this is going to be part of how they get through, the next six to 8 months, and really people starting to use their provider portals. And then lastly, to further that goal of using people in the community to be able to care, we're also seeing we're using funds and grant money to be able to pay for services for folks that don't have access to virtual care. The $50 copay for somebody to be able to get that phone call with a provider online if they don't have access to a service through their existing insurance company, or they don't have insurance. And then we'll talk a little bit later, but we're continuing to see movement of not just virtual visits, but also extending care, using resources like this in our town to get out to patients and actually care for them in their homes, so they don't have to be brought into a facility for care.
Got it. Excellent. Some tremendous insight there. Thank you. It's nice to have that public official sort of knowledge too, and experience that you're seeing there. Brian, I've used telehealth a couple times of late. Once with my primary care physician and once with my neurologist. Both enjoyable experiences. Went well, saved me a lot of time. What was a half-hour visit became a 20-minute visit, and I didn't burn an hour of cycle time getting to and from the doctor and whatnot. Do you see telehealth as being more of a primary care solution or a specialty solution, or does it even matter?
I don't know that it really matters. I think that, it's more of a chronic care kind of situation. I don't know that newly diagnosed patients are going to be happening. I mean, it may get to the point where they say, you know what, you may have something we need to diagnose, and we'd like to see you in person to go through that. But those kinds of visits where, it's a routine check-in, there's a need to monitor this patient, not necessarily major changes in the care plan necessarily, which, again, my pharmaceutical experience, I'm looking at it from a pharma lens a little bit, saying, oh, this is going to be a different view of how the marketplace is going to evolve. Now they can practices can collect more data about a patient, but they may not choose to act on it as clearly as the guidelines might say, because they're waiting for an in-person visit, which might not happen for a bit more. That said, more data is always good. More check-ins with patients, make sure they're staying on the course of therapy. So all important components as we're going forward. So, all indications are this is here to stay.
Got it. Good. Ken, you're one of our futurists and lead our innovation practice at Point of Care Partners. Do you think telehealth will stay around at these levels post-COVID, or could it even expand potentially?
I was just looking at a survey of telehealth use, and there were a few thousand patients, adults that they surveyed. Of these few thousand, about 3/4 of them had not really even been familiar with the telehealth option, and of the 1/4 that were familiar, only 1 out of 5 had actually had a telehealth visit. On the other hand, of the people who had a telehealth visit, many of them had done more than one. So I think there's a familiarity piece that is starting to play a role here. And as we come out of this, both physicians and patients who aren't familiar with this are going to recognize the value. You mentioned, the time that it takes to go visit the doctor. One study I looked at showed that for the 20-minute encounter with the clinician, you were spending 2 hours as a patient, and this is clearly much more effective, especially if you can't travel or there are travel restrictions, older people in particular. Here in the Northeast, when the weather can be very bad, I once saw a video of an older couple, and they had moved to a telehealth platform with their doctor, and they were literally in tears because in the usual circumstance, the wife trying to get the husband down their stairs and out into the car with the ice in the driveway, they just literally couldn't do it. It was, the part of the month that they dreaded, and now this changed the game for them. One of the challenges we have is the fidelity of these visits, and for this early phase now where we're dealing with COVID, for example, and a lot of these are really the only way to accomplish and the safe way to accomplish a visit. You don't have all the medical equipment that you need, in the patient's home. But over time, I think we're going to see these kits that are sent out to patients with a thermometer, digital scale, blood pressure cuff, pulse oximeter, and so forth. For just a few $100, you can equip somebody. And if it saves just one hospitalization, you're way ahead of the game with that. And then other areas like mental health, where we've had a lot of traction with telehealth in the past. I think that will continue, especially now that more people are stressed out and have a lot of reasons to have mental health challenges. And then second opinions. That to me, that's a no-brainer. Nothing more irritating, I think, than having to go in for that second visit and the physician says, "Well, everything looks good. I'll see you again in a month."
Got it. Very good. Excellent. Let's talk a bit about how we productionize this, as it were, coming out the tailpipe of COVID. So how does a given payer or delivery entity take this telehealth model into prime time? First off, let's talk a little bit about financials. So how do both parties, both the payer and the delivery side, make it financially viable to use telehealth path forward? For delivery entities, more visits, but at a lower unit cost, or add on telehealth services, charging for that. And on the payer side, can telehealth actually reduce their medical loss ratio? So let's start with Brian's perspective here and let poll each of the three panelists on this one. Brian?
Sure. So, we were, as I said a little earlier, we had some folks that were actually telehealth providers in a practice, and they were using remote patient monitoring. It was a cardio practice, and the remote patient monitoring was being done centrally by the health system. So they didn't have to worry about the technical pieces of all of that data flowing in and gathering in a spot and being able to do the analysis of it. They had the information all flowing in and an analytics screen made for them that could be snapshotted and sent off. So that took a lot of the effort out for the individual practice staff with getting, you can only imagine getting, daily weights and daily blood pressure readings, and not wanting to overlook anything that was important, but also that the cuff wasn't on right might create an outlier in any given day in any one observation. So being able to work through that. I think the reimbursement issue on the health system side is really proving the value that by monitoring these patients more closely, by having these interim visits between the official in-person visits, that you're able to avoid bad outcomes, ER visits, more expensive procedures down the line, that you're able to monitor and drive this forward. And I think that's the important component. And that's really the hidden obligation right now on the physician side, the practice side. They've sort of been, given these relaxed rules. And now it's a sort of an obligation to show what they can do with it. Because I think this is a giant test case for, is this the way it's supposed to work? I think we know that's how it's supposed to work. Now let's prove that that's how it's supposed to work. Josh, what do you think?
Yeah. Josh, talk a little bit about, as you think about value-based care and the financial impact of this, because that's really a sweet spot for you.
Yeah, that's exactly where I was going to head. So I'm going to be a little contrarian to Brian, because I think one of the realities that we're going to deal with coming out of this is just pent-up capacity, right? How much demand is there going to be in a system that, any of us that have ever had to schedule a specialty appointment understands is hard to come by to begin with. And I think that this ability to be able to use telehealth as flexible capacity management, to be able to manage the folks that you can with a phone call, manage the folks you can with video, or with video plus sort of supplemental tools, as Ken described, I think is going to be incredibly important. There's two sort of aspects of this, right? Which is the how do I get paid and how do I get permission, right? Sort of prior auth and sort of payment to make sure that people stay whole. But I think as we look at sort of the curve coming out of this and starting to find, those people that have been sitting at home getting sicker because they haven't been getting their regular care for chronic care patients, but also just, all the annual checkups, all the skin checks, all, whatever it is, being able to come out of this, and it's going to be incredibly important with payers and providers to work collaboratively here together to deal with just the scheduling aspect and really make sure that the right patient gets to the right place for the care level that they need is going to be incredibly important. I think that, to me, there are already payers in the market, and we see in the news regularly KP reporting on sort of the volume of work that they're doing virtually today with their patient population. I think that the proof is already there. I think, to me, it's the nudge to move people forward and to really ask themselves those critical questions about how they're going to deal with this onslaught that's coming towards them, and how do they do it in a way that, because we are moving into more and more value-based contracts, are at the best price point for the right level of care for the patient at any given point in time. And that is something that we're seeing happen between people that are really focused on those partnerships and those moves to value, really having those hard conversations now about, relaxing or extending existing prior authorizations to deal with folks that, are missing appointments or elective surgeries that have been canceled. And that we're also seeing just really grappling with the, how are you using your pharmacist? How are you using your virtual capacity that you've got, whether at the payer side or the provider side? And then how are you dealing with, your minute clinic type of assets to really be able to deal with all of that demand that's going to be coming towards the system. So I'm not as concerned about sort of there being a proof point to show that it works. I think it's more about making sure that we keep each of the players whole as we move forward. And, there are active conversations happening between payer and providers that are already in at-risk contracting about how are they really weathering the storm together.
Interesting. Kind of a little spin on that. I've heard some discussion about some payers thinking about maybe just dropping their downside requirements of value-based for 6 months or 9 months or whatever until some of the providers get a chance to flush out post-COVID and things. So that's actually a little bit of that conversation going around the marketplace. Ken, how about from your perspective in terms of the financials around this?
Yeah, from a payer perspective, one of the barriers has been, well, we're going to pay for this telehealth visit and it's not going to be very high fidelity. So the patient's going to end up going in to see the doctor anyway. So now we're paying twice. I think that's a little less concern now. And especially we don't want conditions to be untreated for longer and longer because people can't get to a physician and then have it cost a lot more later on. From the provider point of view, one of the big barriers had been the cost of the actual, audio-visual equipment. And you don't have to go back very many years where that stuff was pretty expensive. Today the infrastructure is almost free, and that can be a huge savings right there.
Hey, Gary, I think that there's also a point that, on the public health emergency that we have in place right now might also, there's some thought that this might not be the only one we have, that there might be a future one coming. And I think that we're stepping up the expectations for physicians, practices, and health systems to be able to handle this in stride in the future. That if you don't master it now and have it under your belt, you're going to be behind the times if this were to arise again, and all of the elective procedures get pushed off, all of the visits get pushed off to start a patient on a new course of therapy. This is definitely going to change the environment. It's the sort of that new normal kind of thing people are talking about.
Yeah, if I could add to that, if you're waiting to the very moment that the televisit starts to try helping the patient as the clinician, this is how you navigate this platform, or the doctor isn't familiar and they're hunting and pecking around, you really want to have a bit of a pre-televisit take place where a lot of those issues are worked out, a little practice session, if you will, so that when the clinician is on, that encounter is the most valuable and not bogged down.
Ken, I had one practitioner say it is really difficult to get a 73-year-old to point their phone camera at their legs so you could do a diabetes visit and understand if their injuries and any issues in their feet or legs are in place. You know, they spend a lot of time looking at the floor and not the actual legs.
And tell me we don't know people who still have flip phones or don't have cameras on their laptops. So there is an infrastructure at the patient end. You're bringing up a really key point here that has to advance for this to really take off.
Yep. So I'm gonna disagree with you guys a little bit, because I'm gonna tell you each one of us is getting closer to being a 73-year-old every single day. It's just reality, right? And when we talk about 70-year-olds today, we're talking about boomers, right? And most of these folks are really well equipped and are pretty technically savvy. And I think that sort of that conventional wisdom, I think we can push on a little bit. And if they can't do it themselves, they likely have a caregiver or a child that is available to help them through that. I don't think it means that it's insurmountable, but I have, 40-something-year-old friends that are just as challenged with their phones as the average 73-year-old. The one thing I would like to share, and again, I have this really interesting seat at the table. So we've been talking in town since I got elected about this mobile integrated health platform, and really working with our local hospital system that's been, like everywhere else in the country, acquiring the local practices. My multi-specialty practice was acquired a couple of years ago. And the barrier, everybody agreed that it was great. My town was raising the hand for our firefighters and our VNA to really be, pilot users of the system. The hospital is about 2 towns away. We only hire firefighter paramedics now on our staff, and really have capacity to be able to do care here. I think as we look at sort of how the world is headed, the barrier to getting that project off the ground in a large part was sort of which town was going to go first and how were people going to get paid for it, right? So you take what's happening today and that virtually disappears, right? That gets sorted, people figure out a model. And we announced this past week that we're going to literally start using people that are physically on the ground and are the first responders for patients to be able to go in and do some of this initial contact when a virtual call doesn't work, or to help somebody do a virtual call. And I think that is game changing, right? Having a nurse from a call center that's part of our VNA team or our volunteer team talk somebody through their first virtual visit. Imagine trying to get that done 6 to 8 weeks ago. It just never would have happened, right? And sort of all of these sort of business process contract issues are sort of just getting pushed through. And I think the onus will be on all of us to make sure we don't backslide coming out of this.
Yeah, good point. Very good point. So I think the cell phone numbers, if I remember, are something like 93% across the country, and smartphone is 85% of that or something like that. So I think just having the tool isn't necessarily a barrier. Maybe competency might be, and some of that's just exposure and whatnot. It's hard to think of any millennials that need somebody to show them how to use the phone or flip the viewer to the other side of the phone or whatnot. So, Ken, as a payer out there, there's a lot of telehealth platforms out there. As a payer, do you need to have multiple platforms potentially, or you pick one and go?
I think that's comparable to a question of how many portals are out there. And you as a patient could be dealing with a payer portal or a payer telehealth platform, or one of your providers may have picked a particular telehealth platform. So you'll hopefully be able to adapt to all of those. And it should be great if we could get the industry to consolidate on just one or a few platforms, but I don't think that's very likely just yet.
Yeah. Do you guys see a market opportunity for an anti-telemedicine fraud type of app out there? Something that's maybe running some AI against telemed recordings and seeing if they were really done or not? Or it just seems like an area that's ripe for fraud to me.
If I could jump on that one, I was just looking at a study that showed that an audit done by the feds in 2018 on telehealth with Medicare, half of the encounters that were paid for when they went back and looked did not see the adequate documentation to support that payment. So that's a challenge. And the fraud has always been a challenge, I think, with telehealth. You can look on the internet and see cases where the fraud is literally in the billions. Now, I tend to think that it would be much harder to fake a telehealth visit than just a regular office visit where you claim somebody came, to your location. Here you could have potentially, saved video and audio, but AI could be used to fake those. So you're right. I think we're going to need some advanced tools to try to stop fraud for the few who are going to try to abuse this system versus the many that could gain a lot from it.
Good. Let me throw out there put on your consumer hats for a second, your patient hats or your member hats, depending on your perspective, right? Is it better for you to do a telehealth visit from your payer's platform, from your provider's platform, and maybe a third-party trusted app? Any thoughts on that? Does it matter in the end?
I've got a view on that, but I know Jocelyn wants to go first.
Okay. And Jocelyn, why don't you start, dear?
So I think there's a couple things. I think that all things being equal and data being able to flow and be liquid, it shouldn't matter what platform I pick, right? Mm-hmm. And I think now more than ever, this is my plug for standards, right? Now more than ever, it is critical that wherever patient care happens, that data flows back to all the parties that are responsible for caring for that patient. And if we can do this with standards, I think you combat the fraud topic that you brought up. I think that you make it able for the patient to pick what works for them on demand at a given point in time best, right? Which is really what matters. And I guess probably tying back to the other tail end of that conversation, it shouldn't matter where I'm getting my care as long as I'm getting the care that I need as a patient. And it should be a free market economy at the end of the day, right? I'm a capitalist by nature. Whoever can provide me the best, richest experience should get my consumer dollar, right?
But I understand you may want to choose a practice that has a telehealth option, but to randomly choose another platform and another physician, there's an asset in continuity of care, right? Okay. And so you could say, well, interoperability says that other physician can get access to the data, but he doesn't have time in a normal visit to digest, all of the data that's been captured about a particular patient and to be able to sift through all of that material. So, I have an earache is unrelated to my diabetes, seemingly, and so I can see a physician for an earache and maybe get that diagnosed and get a medication or a treatment plan put in place. But if I'm having a diabetes event and I go see another doctor, how is he going to have the continuity of care that my regular physician or my regular care team, nurses and practitioners that are within the practice that I normally see? I don't think there's real value in that outlier visit, if you will, with another physician. I think that's the marketplace, and patients are going to be hard pressed to find the value in those kinds of interactions. Will I go to a practice that has the availability of that as an option as part of my regular care? Absolutely. Will that be the midnight visit because I have an earache and I need to see a doctor on demand? I'm not going to get the continuity of care in that because it will be an outlier physician, even if my practice arranges the covering physician or the wraparound coverage from a third-party service that has those physicians. You just don't get that continuity that I think people are going to expect. And so, maybe it's a wait until morning and get that early morning visit with first available video, virtual visit.
Yeah, I think you guys have this just right. I mean, you've got a question of what information is going to be available to the clinician at the point of that visit. Is it just a transaction that is attempting to make it as short as possible and they want to access the least amount of information possible? Or do they have access to your EHR, to your payer data? Are you connected out to an HIE where you can pull information from a lot of places? And then at the back end of that, when it's over, when it's documented, where does that information flow? Does it get back to your payer? Does it get back into your EHR? I think that's exactly right.
I think this is a
Great.
really incredibly important point, and I think that it really hasn't come in our conversation, is that there's really classes of care, right, in situations that are going to be more prone and ideal to do virtually. And I think, as Brian's discussing, that when you're really looking for that patient that's dealing with a chronic condition or behavioral health issue or whatever it is, that continuity within the practice that you're in is so much more important versus a flu vaccine or an earache or something that is akin to what you could do at a local health stop.
Right. Very good. Excellent. So let me I'm taking some notes as we've been talking here. Let me just kind of summarize what I heard. So first, both payers, delivery entities, and pharma companies need to plan for telehealth to be prime time going forward. This is not something that's going away. Probably going to expand. You're probably going to have to think about how you're going to productionize it in your operations. Probably is going to require some business transformation. And it's likely going to require a whole heck of a lot of interoperability. Okay. So that was one point. I heard that there might be a need for multiple or different telehealth platforms depending on what the entity is. So you might need to look at some of those out there. As a delivery entity, you probably need to re-engineer some of your processes. Certainly, your intake process, where you're used to having an LPN or an RN do intake and then eventually see a doctor sometime during that visit. For pharmaceuticals, you need to be prepared to support your physician and their practices in the use of telehealth. So this is something that could radically change the scripting process out there and the volume of scripts and whatnot, and also the opportunity to change scripts more rapidly perhaps than they are currently. And as a payer, you need to provide an option for those in your delivery network who maybe don't have the wherewithal to get there on their own. So if you're a big health system, you probably got telehealth relatively figured out. It's a question more of expanding it and productionizing it. If you're a standalone, single shingle doc out there or small ambulatory practice, then you may need some help, and probably the payer's got to help you with that in order to keep you competitive. So let me, how about just some closing thoughts from the crew here? Josh, I'll start with you. A minute or two of closing thoughts, and then we'll wrap up for this session.
So I think similar to a number of the conversations that we're having now and we'll have in the coming weeks, that I think, Gary, you do a great job of summarizing. What we're really talking about is what's the business process change management that's happening inside of practices to really reform sort of how and where you're applying your resources. But that's already underway in so many practices across the country, right, as they move into at-risk contracting or value-based care contracting with their payers. So I feel like if we think about sort of change in the industry as a flywheel, that this is essentially an accelerator to that, right? It's a big shove forward. And the question is sort of, as we come out of this, how do we either ensure that we're putting the resources in the right place, or that people are able to make those permanent changes to the way that they actually do patient care in their practices. And I'm optimistic that it will help. I think we'll see practices that will struggle with it and payers that aren't nimble enough to really support and handle it. But but for the folks that are innovative and are really thinking thoughtfully about this being really business process change and not just a temporary problem, they'll be able to succeed.
Very good. Brian, as our guest today, what closing thoughts on telehealth?
Well, I think the real opportunity is to try and influence and help the adoption of using these technologies to improve the care of patients, whether it be that rural patient who's now accustomed to a telehealth visit or a virtual visit, or a patient maybe in inner city who found it difficult to get to the specialist appointment, who now has an opportunity to have a check-in with their physician and the practice staff and the nursing staff there. And so, how do we monitor this and really understand what the impact of all of these changes are as we're going forward to prove the value of them, so that this investment can be measured and tracked over time to look at the impact.
Very good. And Ken, closing thoughts from your end?
In my grandparents' generation, doctors made house calls, and sadly, the hospital is where you went to die. And today, telehealth is effectively becoming, the 21st century version of a house call, and where you're surrounded by your family and loved ones. And I think in our COVID challenge right now, we're going to see the value of this, and it's going to really turn a corner.
Nice, very nice. Thank you all. Well, that's our time for this edition of The Dish on Health IT. Many thanks to my co-hosts Jocelyn and Ken, our inaugural guest Brian Bamberger for taking time today to join us, and thanks to everyone for listening. We'll be back in a bit with the next edition. Please subscribe to us at whatever podcast carrier you use. If you have any speaker thoughts or you have comments or suggestions on this podcast, please email us at podcast@pocp.com. Goodbye for now, and remember, Health IT is a dish best served hot. Thank you, and good day.
Thank you for listening. If your organization needs help understanding the shifting telehealth landscape and developing an action plan, reach out to us at info@pocp.com.